Giovanni Traverso is a professor of engineering at MIT and a gastroenterologist at Brigham and Women's, and we're very happy to welcome him here today.
Thanks so much, Lisa. Let me just dive right in. These are my disclosures. I do a lot of work with our own companies and others to help them bring technologies to the bedside. The focus of our group is really around developing new systems for drug delivery and sensing via the GI tract. And really, if I had to sort of find a single phrase or quote that helps drive a lot of the work that we do, is the one by this gentleman that I think we all recognize, that, simply put, drugs don't work if people don't take them. And so really, a lot of the work that we do revolves around how we can make it easier for patients to really stick to their medication. And this is really motivated by the observation that over 50% of folks out there fail to adhere to medication as prescribed, particularly in chronic settings. And what we've recognized over the past couple of decades is that this is an enormous burden to our healthcare system. And this is an editorial from the New England Journal from a few years ago, really highlighting the magnitude of this challenge. And from a cost perspective, non-adherence or non-compliance generally manifests in excess expenditures in avoidable hospitalization, somewhere between $100 to $300 billion annually in the US alone. And if we consider the potential to modify adherence and really improve adherence, if we take, for example, hypertension, were we to improve adherence for antihypertensives, we stand to mitigate the premature deaths of nearly 100,000 individuals. And so recognizing this challenge, actually the Gates Foundation came to us several years ago, about 7, 8 years ago now, and asked if we might be able to help develop systems that could facilitate dosing in the field, particularly focus more on antimalarials, medications for HIV. And so, we really put our heads together and really honed in on a single observation. And that observation is that if we make it easier for patients to receive their medication, we stand to actually transform or increase adherence rates. So here's some data. This is from a review from the New England Journal looking at medication dosing frequencies. And so if you look at on the far left, you have a medication that's dosed every 6 hours versus on the right, so your left, one that is dosed once a day. And what you start to appreciate is that, not surprisingly, adherence or compliance goes up. Now, this observation has been extended to medications that are dosed on, or can be dosed, I should say, on more infrequent time scales. So, for example, bisphosphonates that are used for the treatment of osteoporosis can be or are available in formulations that are dosed weekly or monthly. And what's been observed is, as that interval increases, the persistence rate or the adherence rate also increases. So, with this data in mind, what we started to really think about was, could we develop a system like this? This is a cartoon from The Economist, talking about some of our early work, and really, I think, captures what we're trying to do, and that is to develop an orally delivered metered system, hopefully in a form factor that's a little bit smaller than the one in the graphic here, but I think provides at least the essence of what we're trying to do, which is that metered dosing over a prolonged period that is easily deployable through the oral route. Now, the challenge that we face in doing this is that the GI tract has this incredible capacity to transit material as we experience daily. And that is that if you ingest something, it typically passes through you in about a day. And so if we consider a standard capsule system, typically you ingest that, it'll start to deploy its contents, and that drug will be absorbed in the small intestine relatively quickly in the order of hours. And certainly we can slow that down by modulating the friction or interaction between the dosage form and the mucosa, for example, using mucoadhesives, and that could get us a few hours. But really, what we want to try and do is develop systems that can stay in the body for multiple days, multiple weeks, or even multiple months to provide a sustained release or drug release over that time scale. So let me walk you through some of the key challenges that we face and how we started to overcome each one of those. So the first challenge that we face in trying to develop such a system is essentially overcoming what at least I refer to as the ship in the bottle problem, which is how do you get that ship through the neck of the bottle? And in order to do that, you have to fit it in a capsule. And so encapsulation is the first challenge, and therefore we need systems that either expand or that are foldable, but after ingestion will deploy. And what you see there is an early video of some of the early testing of these systems that were deploying from a capsule and assuming different shapes in the stomach of a pig. Now, following deployment, we need those systems to be retained. They have to stay in the stomach. They have to protect the drug for a prolonged period, but then also provide that controlled release. And then eventually, whatever is retained needs to dissolve or break up and then be excreted through the body. Now, as we set out on this journey, typically the first thing that we think of has to do with safety, and what could be the worst thing that could happen. And, one of the worst things, at least, with my clinical hat on, that could happen if someone ingested a system that was residing in the stomach is that it could get stuck. It could get lodged in the small bowel, particularly at the junction between the small intestine and the colon, where there is a constriction called the ileocecal valve. And if that were to happen in sub-Saharan Africa in a research-constrained setting, it would be catastrophic. And so we wanted to build into these systems some safety mechanisms to help mitigate that risk. So one of the first things we did was develop a material that we refer to as an enteric elastomer. And so it is enteric because it is more stable in the acidic environment. And so what you see in this graph at the top is that material over the course of days in an acidic environment. In SGF is simulated a gastric fluid with a low acidic pH. And when the material is placed in a near neutral environment, SIF, which is simulated intestinal fluid, that material starts to break down. Now, we call it an elastomer, and as you can appreciate on the far end of the slide, we can stretch it. And we needed this material to have these properties to facilitate encapsulation, so that folding of these structures, and then also to impart an added safety valve, essentially, or mechanism in the event that one of these systems passed through the pylorus, so through the stomach, into the near neutral environment of the small intestine. And so what you see here in the top panel are some of those early prototypes. We see a circular structure with these intervening enteric elastomeric pieces with another polymer. The polymer that we use at this time is a polymer called polycaprolactone that's been used in many medical devices, but also even in cups and other goods that we use daily. And then we showed that we could fold these structures, place them in the capsules, and then when placed in simulated gastric fluid, capsule would dissolve and the shape would resume or assume the shape it was designed to. And then when placed in simulated intestinal fluid, those linking segments would break up. And so we started iterating on these different shapes. So we looked at star-like systems. And so what you see on the left are some of those stars opening up in the stomach of a pig, or hexagonal systems, as you see on the right. And so part of the development also involved tuning the properties such that these systems could come out of the capsules in the desired time frame to ensure that they had the dimensions to achieve effective retention in the gastric cavity. So let me just give you a little bit of an up-close and personal view here. This is a video of one of these early prototypes at approximately 35 days post-deployment. There's a couple of things I want to point out to you. One is this star is sitting right over the pylorus of an empty stomach. This is the stomach of a pig that was just fasted overnight. These pigs are on a liberal diet. And what I want to point out is that it is empty. There's nothing that's being held up. And there were over 300 experiments that had been done by this point showing that these systems were not being fouled. They were not generating aggregates. And furthermore, as you could appreciate, the tissue was pink. There was no bleeding, and that, again, was very reassuring. So altogether, by this point, we were very reassured that we had the capacity to deliver a system in a capsule that could reside in the stomach of a large mammal for a prolonged period. But the challenge remained of how do we deliver a drug? And so this work was being done with the Gates Foundation, and they were interested in delivering a drug called ivermectin that's been used for the treatment of parasites, and they were interested in delivering that over a prolonged period. And this is actually the very first set of data for the 3 successful experiments in pigs, noting that we could deliver the required levels of ivermectin, in this case for at least 10 days. On further tuning of the systems, we were able to achieve 2 weeks as compared to the standard. We extended this work, recognizing the modularity of these systems and allowing us to incorporate different polymers, different formulations, and different drugs, and extended the system to include antiretrovirals. And so we tested different antiretrovirals. These are the 3 that we looked at, and we showed that we could essentially develop a single capsule that could provide the required levels of antiretroviral therapy for over the course of a week. And this is just one of those examples. Now, very recently, and this will be coming out in just a few weeks, we've now developed a once-a-month oral contraceptive. And so just to remind everyone, oral contraception has been around for several decades. It is typically taken daily, but we've developed a single capsule that can be taken once a month, and we've been able to show that with these systems we can achieve the levels required. And these are preclinical studies, and we're now translating this work into humans. Now let me change gears and share with you a couple of clinical cases from my time as a fellow. So this was from exactly 10 years ago. There were 2 fascinating cases that really help provide some of the basis of a lot of the work that we do today. And there are 2 cases. So this particular case, as you'll appreciate, is one that is very difficult to forget. And this was a 41-year-old gentleman who had been transferred from the local jail to the emergency department. I remember getting this call saying that this patient had swallowed, had broken glass and swallowed sort of several pieces of that glass. And so I was called to the emergency department at the MGH, and I walk down and I see this gentleman who is handcuffed, but it was the handcuffs with chains, and he actually had a sandwich in his hands and was eating the sandwich. And so I realized there wasn't much as a gastroenterologist that I could do, because given that he had just eaten, that is essentially a contraindication for us to do a procedure, given the risk of aspiration of that sandwich coming up essentially and going into the lungs. But what it taught me was that if the sharp objects are small enough that we could observe the patient, and the likelihood of them passing without causing damage was actually pretty high. And so that's exactly what we did. And so we observed this patient for 48 hours. These were radiopaque, so we could follow them radiographically. And the patient did fine. But really, what it pushed me to do at the time, this time I was a fellow, I presented this case and I did a lot of literature reviews, really to understand the capacity of the GI tract to tolerate sharp objects. And it really gave me a much deeper appreciation for the incredible capacity of the GI tract to tolerate sharp objects. So one of the things that I learned, for example, was that if everybody in this room were to swallow a razor blade, 90% of you would do fine, and 10% probably not too well, but I'm not suggesting we start doing that. But nevertheless, I thought it was an interesting piece of data that I took away from this experience. The second case is a more common case that we tend to see, and this was a 62-year-old lady who had a history of arthritis and reported taking a lot of ibuprofen over the preceding month or so, and came in reporting abdominal pain in the epigastrium, which is up here, just where the stomach is, and reported that her stools were a lot darker, and also was lightheaded. And an endoscopy was performed, and we observed a bleeding ulcer. And one of the things that we do to treat ulcers is that we go in and we inject epinephrine, we inject adrenaline. And the reason that we do that is for a local effect, for a local vasoconstriction. So we try and stop the bleeding, clean the area, and then treat either with clips or cautery. And so, but what we recognize is that as soon as we give that injection for the local effect, the heart rate monitor starts bing-bonging and the patient is tachycardic. And that response is a systemic response. And so we recognize that that injection is fairly rapidly, bioavailable and having its effect. So putting these pieces together, we wondered, well, could we develop ingestible microneedle systems for the delivery of biologics? And so at the time, this was almost 10 years ago, I was a postdoc with Bob Langer, and I spoke to Bob, and I said, look, what do you think if we made these pills with needles? He's like, that might make a lot of sense to a gastroenterologist, but I think we need to try and de-risk this on the safety side. So I said, I agree. So we actually made some prototypes and fed them to pigs. And so these are some of those very early sort of crude prototypes that you see at the top. And we fed these to pigs. They passed easily. We also injected insulin in different parts of the GI tract and looked at the hypoglycemic response and the kinetics of that response, and found that we could induce hypoglycemia by injecting insulin in different parts of the GI tract that was comparable to what could be achieved subcutaneously. So this really set the scene up for a big challenge, which was, we know that we can inject, but how do we do this in an autonomous way? So we wanted to develop an ingestible applicator as such. And so there were three sort of main challenges that were left for us at the time. And so one is, how do we get that applicator to approximate or be in immediate juxtaposition with the tissue? How do we induce the triggering of that injection? And how do we deliver a sufficient, or I should say meaningful amount of drug? And so let me walk you through on how we address this. So for the actual approximation, we took a page from the leopard tortoise that you see here, and basically what we did was we used the shape of the leopard tortoise, but then also the density distribution of the tortoise, similar to a very common toy, the Wearable wobble, to actually help us with the self-orientation aspect or challenge. And the way that we validated this, we did a lot of high-speed photography in different media. We looked at several other shapes to compare, but then we also evaluated these systems in pigs. So essentially, by moving the pigs, we could observe the systems self-orient as compared to other systems that either did not have the correct density distribution or had different shapes. And so through both mathematical modeling on the density distribution and the shape, we were able to identify an optimal shape to allow us to ensure that the applicator could always orient in the right direction. So then the next challenge that's left was, well, how do we trigger an injection event in the gastric cavity, in the stomach? And so we wanted to think about or identify a cue that is universal in everyone, and the cue that we settled on was humidity. And using humidity, we wanted to identify a material that displays brittle fracture mechanics. So think candy cane, not taffy. So we want something that fractures all of a sudden as opposed to gradually. And as candy cane, we actually focused initially on sugar glass as that material. And what we found was that we could study essentially the dissolution of a cylinder of sugar glass and control the timing of the triggering. So let me just show you some of the early experiments. So there's what you're seeing on the right is a spring that is contained in a solid piece of sugar glass, and we are essentially dripping PBS on this spring, and what you see there is within milliseconds, this is high-speed video, the near instantaneous release of the energy from the spring. So, we have the self-orientation, we have the actuation. Now, we wanted to ensure that these systems were small enough to ensure that they could pass through the GI tract. And so we focused on a blueberry size to ensure and maximize the safety. But what that meant was that we probably needed to think of alternatives to standard liquid formulations of biologics, given that you can only fit as much as you can dissolve or suspend for that matter, and that sort of posed a significant limit. So what we did for the drug delivery is we actually made needles of 100% or near 100% insulin. And so what you see there on the bottom right is one of those early prototype needles, and the tip is actually 100% insulin. So we studied the effects of compression and heat on insulin as well as many other proteins and found that we could form these solid needles that have a very high density of the active pharmaceutical ingredient that we're looking to deploy. We tested these systems in pigs, and what we found was that we could achieve comparable levels to those that are achieved when the doses are administered subcutaneously. So that's what we saw, and that's what we're showing right here as far as, and I want to just point you to the middle panel that compares the AUCs for subcutaneous, an intragastric injection in a laparotomy kind of situation, but then a simple administration of the applicator system. And we also did a lot of work around the amount of force that was being exerted on the gastric mucosa to ensure that we were not inducing a penetration event. And so in sum, what we were able to show was that using the leopard tortoise inspired system, we could achieve rapid self-orientation on the order of milliseconds or hundreds of milliseconds. We could tune the triggering on the order of minutes of the release of a solid needle that was made of near 100%, or in some instances 100% insulin in this case. Now, having worked on sort of all these different systems and really doing a lot of work thinking about, well, how do we keep systems in the GI tract for prolonged periods, or how do we deliver a broad array of molecules, not only small molecules, but also biologics? One of the things that our group also is thinking a lot about and doing a tremendous amount of work is, well, if we have the capacity to essentially have a transient implantable system, what kind of electronic capabilities can we impart on these? And then moreover, if we have the capacity for a system to reside in the stomach for weeks or even months, how do we power these systems over those time scales? So this is work that we did a few years ago, and we continue to expand on this, but really inspired by work that, experiments from our high school textbook. So we developed a galvanic cell system where we aim to harvest energy from the gastrointestinal fluid. And we looked at different electrode pairs, and we looked at, for example, magnesium and copper versus zinc and copper. And we found the zinc and copper systems to be more stable over prolonged periods. We then created prototype capsules to just initially characterize our ability to harvest energy from both the stomach and then the small and large intestine. And what we found, to our surprise, if you look up in the right upper set of panels, is that we could harvest everywhere in the GI tract. Certainly the voltage was lower in the intestine, but nevertheless, we were able to observe the capacity to harvest from the stomach as well as the intestine. So with this data, we created a set of capsules that could only communicate if they were successfully harvesting. And what we showed was we took these capsules, gave them to pigs, and showed that we could harvest from the GI tract and communicate externally over the course of a week temperature, and that's what you see right there in the middle panel on the right. And so we continue to expand on this, as well as sensor development and application in the GI tract. Really, our vision is trying to develop ingestible systems that can sense and deliver in response to a range of different stimuli. Now, with that, I want to just thank our incredible team. And this is a drone from a couple of years ago from our regular summer party out on the Cape. If you haven't been to Wellfleet, I recommend a visit. And with that, I want to thank you for your attention.